we are talking about the age differences or the age limits in when and when not to operate. Perhaps I could start by mentioning that the British Medical Journal, in an editorial about 20 years ago, mentioned that a surgeon, a good surgeon, knows how to operate, a better surgeon knows when to operate, and the best surgeon knows when not to operate. Can I have your thoughts on at what age do you think that there is a limit to what we can do for a patient? In other words, how old before they are too old to be operated on? All things being equal, a fit patient, operable patient, all things being equal.
Can I take the ball? Yeah, I think that's a very good question. That's a very nice quote. I always tell them, as I grow older, I operate less. I mean, my indications are less, but I still carry on operating because we always want to do ethical practice, and autonomy becomes very important. So it's a patient's choice. And I think beyond just looking at indications, and one of the important aspects that we have learned from the literature, the evidence, the recent paper from the UK has shown the average age of the surgical patient has grown higher and higher. And they said that there'll be a 25% increase in the number of patients above the age of 75 going for surgery. And this is because of a lot of factors. So I think before we say whether the age, I mean, we are the biggest ages, surgeons are the biggest ages, we have age criteria, when we do and when not to do an operation, but taking everything into consideration, that there's an indication for surgery, the patient is well, the risk of anesthesia is low, I would give an informed consent with the patient. And fortunately for me, in my kind of practice, I do hand surgery. So one of the common injuries we have is the distal radius fracture. To fix or not to fix, it's actually there's no real evidence that one is better than the other. But I leave it to my patient. I have fixed on a patient who is old, and I've not fixed on a patient who is young, depend on their informed choice after looking at the outcomes and the expectations of the patient. Thank you.
Yeah, so you have no cutoff age limit. It is adjustable.
Yes, as long as they are breathing, I'm okay.
Rigor mortis being the only contraindication.
Yes.
Okay. Prof. Raghu?
I think certainly my answer would be there is no age cutoff. Okay, so I mean, it's not like as if there's a magic number where you, on this side of it, you operate, and on the other side of what's this? Oh, okay, all right. So there is no real age cutoff. You know, it's not like as if when you turn this particular age, you cannot operate on this patient. No, I think age is just a number, as we all know, and really the physiological status of the patient is more important. The comorbidity and everything else that goes with it, you know. So if you've got a patient, you know, you might have one patient with perforated diverticular disease who's got very little other comorbidity, you know, and I would operate on that patient, whereas somebody else who's got diabetes, hypertension, congestive heart failure, and aortic stenosis and things like that, you know, what are the chances that that patient will even survive a surgery at 93 or 94? Very, very small. So there is a real ethical consideration here. I think you got to explain this to the patient, the family, and they take that choice. I mean, emergencies is one thing. You might still want to take the risk, you know, for an emergency, but certainly not for an elective procedure, you know. So that's where, I mean, you have to make that distinction. Is this an emergency or is this an elective procedure? And even if it's an emergency, there is you know, if the patient has a lot of comorbidity, that would stop me. Definitely not his age or her age. Thank you.
Dr. Kong?
Yeah, hi. Thanks very much. First of all, for inviting me to this forum. It's clearly a hot topic of interest. And clearly, we are going to face increasing challenges in our practice because, as we all know, the aging population is getting more prominent in our society. Now, I strongly believe that we shouldn't be focusing on chronological age. I really feel that we should be focusing more on biological age. So what actually determines biological age. It's really hard to pinpoint exactly what you look for. There are many criteria that people have used to try to pinpoint what biological age is and how patients will respond to stress of surgery. That's essentially what surgery does, it stresses your body. And essentially, there are various issues that need to be considered, and I think the first thing to consider is basically the physiological reserve of that patient. So no matter whether you are 40 or 50 or 90, we all have a certain physiological reserve. And I have certainly seen patients who have comorbidity from a very young age, and when it comes down to even at 50 years old, they may be as comorbid and they may not have as much physiological reserve as an 80-year-old was able to run a marathon. So I think we need to actually think twice about, trying to discriminate people based on age, whether they should have surgery. I think it should really very much be determined upon what the physiological reserve is and what is the stress that you're going to incur with your surgery. So as Dr. Raghu was mentioning, right, that is, we have patients where you have elective patients and you have emergency patients. And in an elective setting, you can pretty much have controlled circumstances where you can hopefully control the stress, and maybe you might want to offer surgery to people who may not have a huge amount of functional capacity. But with all the resources that you have and being able to optimize the patient, you may be able to get them there with surgery and even prolong their survival. But if you've got patients who present as an emergency, where they are already stressed out and where the physiological reserve is already low, then you might want to think twice about what you're going to offer for that patient. So I think my bottom line is don't focus on chronological age, focus on biological age. Thank you.
Okay, interesting point. Can I ask, can we just move around a little bit and say, we always worry about the age of the patient. What about the age of the surgeon? At what age do you think you should hang up your scalpel? Don't tell me biological age.
So we published a paper on the in the journals last 3 years ago. As you get older, you become a bit wiser surgeon. So we looked at two aspects. We did a survey among healthcare professionals on their views of the aging surgeon. And we generally felt that most of the healthcare professionals, these are people who are involved with surgeons, that means the anesthetists, the nurses, the clinicians, and the managers of hospitals. This is based in Singapore. They generally didn't feel that the age of the surgeon was important, but more the competency and skills of the surgeons. Then we followed up this study with a qualitative study where we interviewed stakeholders in elderly surgeons, both surgeons, anesthetists, and hospital administrators. And they came to the view that as long as the outcomes and the performance of the surgeon was adequate and were acceptable, that they can move forward. My hypothesis, this is just my own personal survey of talking to friends and colleagues who are my age. I won't tell you how old I am. I personally feel that in terms of my, I'm not a great surgeon, but reasonably okay. My competencies and my expertise, I'm at the peak of my career. Because there are some physical, because I do microsurgery, very, very high fine motor movement, they may have slightly decreased, but it is well compensated for the wisdom that I have got and the experience, and I can overcome that. And so just a few days ago, I was doing a complex reconstruction, and my junior consultant booked the case for 2 hours, and I was out of 20 minutes, I was done. And he said, what was the magic? And I think it is that experience. So again, I don't think it's the age of the surgeon, but more the competencies and the outcome. Now, which brings us to the question, how are we measuring our competency and outcome of the aging surgeon? And that's another topic in itself, but maybe you can go to that later. But before I hand over the mic back, I just want to add one story to just now's discussion. When I was a medical student, we used to have a dermatologist called John Petit. He had a clinic above Rose Chan's striptease Saudis in Jalan Tunku Abdul Rahman, upstairs, you know. So I went, he used to go to his clinic, and he had a 68-year-old, late 60s estate worker from Ireland who was a manager of an estate in Klang, who had a basal cell carcinoma on his cheek. So for those who are not surgically inclined, basal cell carcinoma is a very slow-growing tumor on the skin cancer. It takes 20-30 years before it, really goes big. So John Petit told the guy, look, this one doesn't need surgery. We'll give you some 5-fluorouracil cream, which is a cancer treatment of the skin, and before the tumor grows, you will die. So the guy said, okay, but can I go out and discuss with my father before I make the decision? So immediately John Petit said, no, you'll go for surgery. Because a 68-year-old who has a father still alive, I think his history, his genetics says he's going to live for long. You may want to alter your strategy. Thank you.
Okay. Thank you, Dr. Vaikundan. It's a very valid point what you said about audit and surgical outcomes, but not all hospitals do a thorough surgical audit on the surgeon, if you know what I mean. In public hospitals, that is hardly the case.
So I think this is the onus on the surgeon. I mean, you as a professional, that's what a professional is self-regulation to a certain extent. So I recently gave a talk about surgical expertise, and there's a particular procedure. I mean, I used to do thoracic outlet syndrome a fair bit in the UK, but my numbers were getting less and less, and I'm having less exposure to it. And so I self-censored myself in the sense that I no longer do thoracic outlet surgery because I don't have the numbers and I don't maintain my skill sets to continue. And this is something we need to ingrain as part of professional development and continuing professional development for the surgeon.
Thank you. Professor Kong, any thoughts?
Yeah, so I hope that I don't have to be worried about this for too long a period, but essentially I think it's all going to come to us at some point in time. I think that I absolutely agree with Dr. Vaikundan that it should be based on competency. And it has to be based on self-audit, and as you should really audit your own performance to see whether you're up to scratch and whether the level of achievements that you'll be getting with your patients are actually staying the same in terms of their outcomes. I just wanted to digress a little bit. I think that technology may be able to assist an aging surgeon as well. And certainly, as we are now moving more and more towards dependence upon robots, it looks as if it may be able to compensate somewhat for the visual acuity loss and also the fine motor skills loss, because the system is able to compensate for that. And it may be that a system like that may be able to allow a surgeon who's aging to practice further and be able to do things that maybe they were not able to do before. I'm not saying that we have good, strong evidence for that, but certainly that's what some anecdotal evidence is showing, that technology can certainly help. But certainly I have to say that where age comes in also comes with experience, and I have to say that it is invaluable to have people who are coming up to the end of their careers to be around to help coach and to proctor those who are coming up. That is really, really essential, and that's what's really needed at the moment. So I think as long as someone is able to perform and they're able to practice is actually consistent with what their past outcomes have been, I don't think that should be a limit to why they should continue to practice. Thanks.
Okay, thank you. There's another topic that Dr. Prof. Raghu and I were discussing just a little bit earlier. I know both of you are not transplant surgeons, but we were considering that is there an age limit when somebody should be able to get a transplant or not? As an example, I would like to ask, say, if you have a 75-year-old male who requires a kidney, and there's only one kidney, and there's another 30-year-old male, totally eligible for the kidney, would you give it to that man, or the 30-year-old or the 75? Yes, please.
Yeah, okay. I think it's a very difficult question to answer, you know. Um, See, a number of things will determine that, and it depends on the organ procurement and distribution system, the network that exists in the country. How much is the shortage of organs in that particular country? You know, so in some places you will find that they will not discriminate. In other places they will say yes, it has to probably go to a younger person. See, so it varies geographically, but on principle, I would not discriminate. And we have certainly done transplants on 75-year-olds. In fact, there's publications on transplantation in octogenarians and who have done very well, because the expected, their survival is quite a lot. In fact, after transplant, their survival is almost as the same as they would survive normally, you know. Now, so really, I think it depends on the availability of organs. That's the most important thing. There is an ethical issue, big ethical issue here. And it depends again on the physiological status of your recipient. And remember that after transplant, they only get better. They can get back. But then the 30-year-old, if you have to then say, do you give it to a 35-year-old or a 75-year-old? You see who's longest on the waiting list, and you give it to them. You know, now, I know people will argue against that. You know, they will come very strongly against that, and they say, oh no, you can't give that to a 75-year-old. You know, so what we have done in those situations is we've given an organ. Let's say you wouldn't use certain organs for 35-year-olds. A slightly older organ, you wouldn't use it for a 35-year-old. Okay, you'd want the 35-year-old to get a fairly decent, good organ. So what we would do is we would take 2 marginally functioning kidneys and put it into one patient. So we do a double transplantation. We explain the risk. We give a marginal organ to an older person, telling them, listen, normally we wouldn't be transplanting you. However, you know, there is this organ that we can't give to a 35-year-old. It's not the best it's not the best around. It's not the best around. However, you know, this is the best we can give you. Do you want to take the chance? It's probably going to work. We won't give it to you if it won't work. So that is how we get around the problem. But it is a big, a very debatable issue that comes up every single time.
Yeah, you could argue that, you know, if the average lifespan, let's say in Malaysia, what, male is 72 or 74? So if this man is 75, he's technically beyond his shelf life.
Yeah, that's true. But I mean, that's why you know, it depends on which part of the world you're in, you know, and how equitable the distribution system is. In that.
I think Dr. Mahathir will take offense to that statement that 70. But can I just add something here?
Certainly.
I sit on the National Ethics Panel in Singapore. So this is obviously an ethical dilemma, and it's just these kind of decisions, you cannot have guidelines. You can have some broad guidelines based on ethics, but you have to take it on a case-by-case basis. Now, this situation you put forward did come about in Singapore many years ago, when everybody is familiar with Tang's mall, you know, the Tang's shopping outlet in Singapore. The owner, Mr. Tang himself, was an elderly gentleman who needed a renal transplant. And Singapore is the only country in the world that who has got capital punishment, where the prisoner can organs will be taken for donated, will be harvested for donation, for transplantation. So there was a gangster who was sentenced to death, and he wanted to give a named donation of his kidneys to Mr. Tang. But later it came out that Mr. Tang obviously paid him lots of money, and when the person who interviewed him from the ethics committee, whom I know personally, so he told me the story. So he went to interview the donor, and he asked him, why do you want to give your kidney to Mr. Tang? He's an old man and all that. And then he said, this is the prisoner's version, was that he didn't want to give it to anybody. He wanted to give to somebody who will do good to the community. And so he named it. So in fact, I think Mr. Tang went to jail for that incident. So I'm just putting that perspective in there to say that these kinds of decisions has to be, transplant is a totally different area in its aspect, and it must be taken into context, into individual story. We must look at the narrative before we decide on the ethics of it.
Thank you. Prof. Kong?
Yeah, interesting topic actually, and I would like to actually ask Prof. Vai. So, what if we practice in Singapore be if we had a live donor? So, for example, a family who matched and younger, say a grandson who is 30 and wants to donate the kidney to Mr. Tang. Would that be an ethical problem?
No, no. So every transplant in Singapore must have unanimous decision approval for the transplant. So there are 3 members on the panel. So there is a layperson, a doctor from the institution, and a doctor from not from the institution. All the physicians and the layperson are trained in ethics principles. So the role of the ethics is to protect the donor. So we don't go into the physiological optimization of the recipient or even the donor. That's for the clinicians. We just look at it, we protect the donor, that they are not coerced, they are not being forced to do this. And so as long as there's no coercion and the clinicians agree, with the ethics will pass that transplant.
Donation is a completely different ball game altogether. You know, we were talking about cadaveric donation earlier. You know, so I think that is a completely throws a different level of complexity. But normally, if a 30-year-old wants to donate to a 70-year-old, it's not a problem at all. You know, you're not dipping into the donor pool. You know, the general donor pool. This is between the family. So there is really no objection in that.
Actually, that may not be true. It may be true in Singapore, am I right? That the donor can choose who, if he wants, he can choose who the recipient is going to be.
No, this is only, if you're
Live.
talking about live donation,
Yeah.
you're talking about donation within the family. You can't, an altruistic donation generally is very difficult to pass through any panel in any country, you know.
Okay.
So
Okay,
this is,
Can I ask the live presenters to not use the live mic and use the mic provided by the Zoom, by the technicians, because that's where we are having problems in the streaming and hearing the audio. You should switch off your mic on the stage. No, yeah, I can hear you, but you have to switch off the stage mic because it interferes with the Zoom
well,
mic.
I've been asked to switch on the stage mic by the IT people here because the others can't hear me then.
Okay.
Okay, so are you okay now?
Yeah. That's
You're okay
yeah,
now?
okay.
Okay, that's
Yeah.
great, thanks. So,
And how
Yes.
do I sound, okay? I sound terrible to
you
myself.
sound great as usual, Prem.
Let's carry on.
Yeah.
So I'm also curious on one thing. Is there an age limit? I know to a donor, can a 90-year-old man donate his kidney?
Okay, can I take that? Yeah?
Yes.
Okay, well, you know, it has happened very rarely. I mean, in Colombia, where we did 250 kidney transplants a year, I think out of maybe 500 donors, maybe 1 or 2 maybe above the age of 80. You know, and that is, see, we go not by the age alone, we biopsy the kidney, donor kidney.
Okay.
Okay, now, first of all, when the offer comes to us, we don't say no, because, oh, it's 80, we're not going to use the kidney. No, we don't do that. We biopsy the donor kidney. I'm talking about cadaveric donations here. Okay, so we biopsy, and if there's a lot of, changes and, chronic changes, we don't use it. We have certain limits, when we can actually use the kidney and when we cannot. So when you've got so much of atrophy and fibrosis and all that, we don't use, more than 20%, for instance, the chances are that it's not going to work and we do not use it. So we have a reason, we have a solid scientific reason why we can or we cannot use a certain donor.
Okay.
But just by looking at the number, we don't decline.
So this is for cadaveric transplants. What
Yeah.
about live transplants?
Live transplantation, okay, that's interesting. Now, we have hardly ever used a live donor above the age of 65 because that's what happens. Your nephrons decline after the age of 60. Your nephron mass starts declining. So we know that, and that has already been proven, biopsy proven many years ago. So after 65, we tend, or 60 to 65, it depends again, we do the split function and we see what it's like. And we explain, we talk to the donor, they are quite happy to do it. Then we go ahead and do it, but we monitor the donor very carefully. But it is rare that we actually use a live donor either for liver or kidney after the age of 60 or 65, around that range.
And could we not use the same argument to say that if you are of that age, you cannot donate, that you have no right to receive?
No, I think there are two different things altogether. I think donating is one thing. See, okay, what about cadaveric donation? If I'm 70, will you consider me for cadaveric donation? Not live donation, cadaveric donation. That is after I die, after I'm brain dead. Will you accept my organs, or will I want you to accept my organs? Yes, of course. If at 70, if my organs are good, why don't you use it for somebody? I'm perfectly happy to give it after I'm brain dead. But when I'm alive, the risk is too much for the donor, because the donor may have another 20 years to go. So you don't want him to go into real, that one kidney to fail because of diabetes, hypertension, whatever it is. You see, so they are two different things altogether.
Okay, but you did say that, after 60 to 65, nephrons and the like decline. So even if you are 70, it's unlikely or relatively less likely that you will have a good kidney.
Well, we have expanded the donor pool. We have worked on it. We've expanded the donor pool, and we do dual transplants. So we will take, if my nephron mass of the donor's nephron mass has gone down by 50% at the age of 75, we take both his kidneys and transplant into one person. So we do a dual kidney transplant, so that way, if you add both together. So we have expanded, we've learned to expand the donor pool considerably by modifying our techniques.
What do you mean? You transplant both kidneys into the same person?
Into the same person, yes. That's right. So you put both in the left iliac fossa, one in the left, one in the right iliac fossa. Usually one above the other. That's what we do.
Would one not suffice?
So, no, because the nephron mass is too low.
So for the elderly you use...
Yes.
Okay.
That's right. If it's an elderly donor, we would use two kidneys.
So it's a kidney and not the recipient?
No, the donor, two kidney donor. So the recipient will have 4 kidneys, 2 that are not functioning and 2 that are functioning.
Okay.
Marginally. So there are various things you can do, So I think there is bottom line here, guys. What we are saying is, there is no age limit for any surgical procedure, transplant or otherwise. There is no age cutoff. You've got to look at the situation individually, see how you can work around it for the benefit of your patient, basically.
I understand.
Yeah.
Vaikundan, it's good to see you. Any questions? Anything else you'd like to add?
Yeah, I just look at it in a slightly different perspective. Many years ago, I heard somebody say, health is too important to be left in the hands of doctors. And actually, it was a paraphrase from a senator in the US Congress in 1916 who said that wars are too important to be left in the hands of generals. So I think that technology and the advancement in medicine is such that we can do anything to anybody. However, as part of ethical practice, social justice has to be maintained. And I think this is where things of this kind of questions must be answered by a multidisciplinary ethical committee or a board who would look at this and look at the demand and supply in that community. Just because it happens in America doesn't mean that it is right for Malaysia or right for India or wherever we are. So this is where we need to contextualize these sort of challenging issues based in the local community, and it has to be transdisciplinary. I will not allow a transplant surgeon to make that decision without taking into account the psychologists, the social scientists, and the needs of the community as a whole.
I agree, yeah. It varies from country to country, and like you say, the ethics. Your ethics panel, is it a fixed panel or is it something that's fluid, that they change every few years or so?
So they're trained individuals. So we have a large pool. So there's like a roster, and we also have an emergency roster. Because sometimes there are urgent transplants, like a liver transplant can be urgent. And I remember I was called at 11:30 at night. I never get called to do a emergency hand, but for transplant I ended up, and we finished at 3:30 in the morning. So yeah, so there's a pool on which we can tap, because every single transplant, and we do a fair bit of transplant, liver and kidneys in the country. So I get called every 2 months to attend, but I have about 60 of us in the pool.
The committee is fluid, not the ethical principles.
Yeah, I'm just curious, Prof. This liver transplants, is it mostly now cadaveric, or do you all still do live donors? Partial livers from live donors.
Also mainly live donors, yeah.
Yeah. So there are no ethical issues in that?
Well, there are definitely ethical issues
Yeah.
in that. And if I remember right, the numbers are Singapore has only the organ donation, cadaveric organ donation rate is only about 2 per million population, whereas in America or in the UK it's about 20 or 30 per million population. In Malaysia it's under 1 per million population. So I think we all have to rely on live donation in this part of the world, which also doesn't happen that much. Any good, robust transplant program should have live donation as well as cadaveric, mainly cadaveric donation, because not everybody can be a live donor because of the anatomy, because of the steatosis in the liver and things like that, and because of other family, issues. If this person is the only breadwinner, do you want to put him under the knife to donate to somebody? So these are the issues you need to think about, and I think we rely over here on live donation because we do not have a robust cadaveric donation program. Although it's there on paper, it is not functioning as well as it should be functioning.
And do you not think that the risk to the donor, it is not entirely risk-free?
I mean, there is a 1% mortality, published mortality of 1% to the donor. That is, if you operate on 100, one may die, and but this is never really even been officially published. We know that we hear about, some people, dying after donation. In fact, in New York, before I started my fellowship, there was one donor death in a certain hospital, and all hell broke loose, and there were no live donations for a while after that. So it is the risk is not zero for live donation. That is the reason why you must have donation after brain death, which is what we call cadaveric or diseased organ donation.
Okay, thank you. Gentlemen, is there any other issues you'd like to raise? I know this can go on forever, but perhaps we can give the audience about 10 minutes to ask any questions. Would that be all right with you?
Yeah, sure.
Sure. I'll open to the floor. We seem to have a large pool of donors here.
It drifted
From
to,
From age to transplant.
aging to transplantation. I tend to do that very often. Sorry, guys.
That's okay.
Yeah, that's Raghu's thing of hijacking the meeting.
Yeah, he does that all the time, doesn't he? I do not think there. Any questions, anybody? Sure.
Can we just come back to the aging surgeon issue that we were talking about earlier? I think Dr. Kong mentioned about technology helping the surgeon. Actually, the other side of the coin is the technology may actually stop the surgeon, an older surgeon, from operating, because he's not familiar with technology and they don't want to accept new technology. So that might be a limiting factor for older surgeons now to actually, shy away from doing, newer procedures, laparoscopic procedure or robotic procedures, because they don't want to learn it. So that's one thing. The second thing I want to say is I want to give an example of an aging surgeon. It's my father. So my father is now 95. He's a surgeon. He was operating until he was 80 years old, and I did his last surgery with him. I assisted him, and he was doing a hernia, and at 80. So I said, okay, let me assist you. Come on, and I saw him, and his hands were rock steady, rock steady. But I could tell that there's a lot going on in his head, in his mind. His body was also okay, he was reasonably fit. But he was going through some sort of stress, every time he was doing this sort of very simple, straightforward procedure. And after the surgery, all went well. I told him, Dad, do you really want to do this? Look, you're stressing yourself out. You never batted an eyelid, 20 years ago doing this sort of stuff. But today, with the smallest procedure, it's not the physical, it's not that there was anything wrong with the way he was doing the surgery, but the stress he was going through mentally, I could see that. And I talked to him about it, and soon afterwards, in a few months' time, he stopped operating, So he was operating till he was 80. So I think it's not the physical aspect of it also, it's the mental, emotional aspect that actually you must take into consideration for the surgeon, who might not be able to perform properly because of that, not because of a physical, any physical issues.
Okay.
Can I just add something to that? 15 years ago, I think Professor Nathan will remember it. I think it was the first Malaysian International Healthy Aging Conference, and I happened to attend. And there was a symposium on aging and surgery, and there were three members, two elderly guys, and myself, a young fella. So there was Professor Bala Subramaniam, who was then the ex-dean of the, or vice dean of University of Singapore, who was my mentor in orthopedics. And then there was Professor Robert Fo, who was a well-known hand surgeon. And then myself. I spoke the easy part about aging, disease, and surgery. Whereas the other two talked about the aging patient as a whole, the physiology, and Prof. Bala talked about the aging surgeon. And somebody else from the audience from the States, from the US, also made a comment. How do you cope as an aging surgeon? Now, I'm in that group. I'm happy to say I'm 65 years old, so I'm not that old, but still young. As an aging surgeon, sometimes it's difficult for us unless we do formal audits. I at the moment still carry on with my audits and the outcome of my work, and I've got others who look at the outcome of my work. Weekly, we look at our outcome. So somebody will tell me off if I am not doing it properly. But this guy said, have a good mentee as your friend, and tell him, because he's your mentee, to inform you the day that he is worried about my surgical competency. You trust him more in that respect than some of your colleagues who may be professionally jealous. So that's one good take-home point I learned. And the second take-home point was, when you become a little bit older, then you are the wise lion in your jungle. Get a young lion together and you operate together. You provide the wisdom and guidance and the mentorship, while the young guy takes on the technological aspects, the technique, and then get proper outcomes. And I think that's how you marry the aging surgeon with the existing surgical workforce. Thank you.
Surgeons, we're all egoistic fellows, right? I don't know.
That's what bothers me, you see, that you know you are not as good as you used to be, but you don't want to acknowledge it, especially if you are in the private sector, if you're alone, and that is your sole source of income.
So in the US, there's a voluntary program. When you reach 70, you go for an annual checkup. It's a voluntary. I think it's every 2 years. You get admitted for 5 days into a center, which actually gives you the license to carry on practicing, where they assess you with a neurologist, psychologist, with ergonomics and everything. And I think you also have to produce a video of an index procedure taken recently, both video and audio, so that they can see whether you're not shouting and screaming and that your performance is okay. And I think here is where revalidation and accreditation, credentialing will come in. So in the UK, there's revalidation. So every 5 years, you need that license. And in the license for the surgeon, so this is where between the employer and the stakeholders have to decide what are the criteria I'm going to look at to make sure that the aging surgeon is not dangerous to society.
And how is it in Singapore? How is this assessed?
So Singapore at the moment is after the age of 67, so I got 2 more years, you will be on an annual contract. The annual contract is pending your performance, your medical checkup, that you must be physically fit to carry on work. And in your performance, we take into account 5 areas: your clinical, your administrative, research, and your education. So each of them, they will measure you. If you fall below par, you will come before a review. So if your clinical area shows some areas of concern, then that is brought up. They may reassign you to do maybe more research and education. So that can go on to a while. So as long as you're clinically producing the output with good outcomes, I'm okay, touch wood, so I will stay here for a while.
And therein is the crux of my argument, Dr. Vaikundan, that not all countries follow this.
Yeah, but you see, do we want regulators to do it? or should we do it ourselves?
I think we should do it yourselves. Self-regulation is probably the best, but that
Exactly.
doesn't always work out translated into a proper audit.
But this is where the medical council, the Malaysian Medical Council, can wake up and do something more proactive, is to keep the logbooks of every surgeon. And in the outcome section, there has to be filled in. So your annual practicing license cannot be renewed if over the last 5 years you have not done a single operation, then why are you being, that sort of thing.
Exactly.
So the outcomes can be based on your specialty. So if you're a transplant surgeon, I want to know how many of his transplants are being rejected and coming in for removal of the organ. So that would be the rejection rate, which may not be the surgical, but you need some surrogate measure to ensure that we know the outcome. So, and I think it is for us as surgeons to advise the medical council, and if the medical council doesn't want to do it, then the College of Surgeons or whatever that we are in have to do it for ourselves. And so I think the logbook for the surgeon is an excellent platform, because even the trainees have to maintain the logbook. So in the UK, the logbook, I don't maintain my logbook, but my trainees, every time they log on, they have to put me as a supervisor. My logbook gets populated automatically. So I have my logbook that I can show to anybody anytime. If anybody has concern, that's an audit trail for somebody to go back and look at my cases and tell me, hey, this guy's cases are all failed or something like that.
Okay, I think, thank you, Dr. Vagundan. We are running a little short of time. We've just got a few minutes. Are there any burning questions? No?
Could I just ask the audience something?
Yes, Prof. Kong.
So it just seems as if, you have 3 surgeons here. 3 of us seem to not discriminate patient on age. And, I just wondered from the geriatrician's point of view, would you then be worried that we might be subjecting patients to fairly stressful procedures, and you're worried whether that might be the right thing for that patient as geriatricians?
I'm sure they heard you. It's always, in a way, amusing that when we say the risks of surgery, it's never to the surgeon, it's always to the patient.
Yeah, that's correct.
Yeah.
And I think particularly so if there isn't a dialogue between the surgeon and whoever that's also involved in the patient's care, that the whole story may be lost, because we are now so compartmentalized in how we manage patients that I may be thinking solely from my specialist perspective, but I'm not maybe making the right decision for the patient if I didn't have all the information that I needed from other sources that may be also very relevant. So I think that's why in University of Malaya, I'm very, very blessed to work with geriatricians who we actually form a team, and we actually have a sports medicine consultant with us as well, and also a nutritionist. So we actually highlight patients that are of particular risk, and we actually form an MDT just to deal with these patients, away from just dealing with the oncological side of things, but mainly just to deal with the patient side of things, to ensure that the decisions that we make for the patient is the right one. So I'm not sure whether I hope that that's the way forward, and I would like to actually hear from others what their experience have been with their surgeons that they've been involved with.
Okay, just before we end, I just like to ask you, sometimes you get an elderly patient who to you is fit for surgery, but what if the relatives or the children say, oh no, my father is too old? How would you manage that?
Should I take that question?
Oh yeah.
I very much practice on what the patient wants, because ultimately it is the patient that needs to make that decision. So I will counsel the patient, the class come home, and until they actually fully understand the benefits and the risks of surgery, and what would be anticipated from that surgery. So if it's quality of life that they value rather than survival, then as long as I have counseled them sufficiently to make that decision, then obviously we'll stand by it. So yes, the family members have some decisions. Their role is actually is mainly to support the patient's decision making. That's how I feel about it, rather than actually making the decision for the patient.
Yeah, so the final call, the final decision is with the patient and not with the family. Dr. Vaikundan?
Well, I don't know. My ex-CEO of my hospital quotes this case very regularly, and Singapore is a very difficult society in many ways. So there was a 68, 69-year-old gentleman who needed neurosurgical intervention. And he was a bachelor young man, lived alone. And he had a poor outcome from surgery. He ended up in a vegetative state and with a tracheostomy. And he was sent home, and he was looked after by his octogenarian patients. And he's remained alive for many years. And I think that is one of the aspects. So this autonomy works well in a Western context. But we, from the Asian context, we need to be very cognizant of the fact that these ethics may not necessarily follow our ethics. And I have said this over and over again. I sit on my hospital's ethics committee. Many a time, local social and cultural context is not taken into account. So if an individual man, a single person who needs the care of his family, who are then maybe even financing him because through their whatever resources, then it should be a joint decision to a certain extent and not just pure autonomy. And we have overridden patient autonomy because from the ethics point of view, because we found that it is not under the realms of social justice, and he may not realize that he may be harming himself and his family. So this again complex situation, and I think in that sort of situation, I would escalate it to the ethical committee to help us make that decision.
Thank you, thank you. I think I'm getting signals from all over, and I hear the rumbling of the stomach from the audience. I think it's lunchtime. Perhaps we can end it here. Thank you, gentlemen. Prof. Com, thank you very much. Dr. Vaikundan, always a pleasure. Nice to see you.
Thank you very much. Thanks, guys.
Thank you, Prof. Raghu.
Thanks very much. Bye.